Welcome to the AUA's all-new monthly podcast series that focuses on leadership and business topics relevant to the entire urologic care team. Please join us each month on the Inside Tract as our subject matter experts explore various aspects of today's rapidly changing business environment. We hope you enjoy this episode, a primer on private healthcare insurance in the United States, with Dr. Micheal Darson and Dr. Jonathan Rubenstein.
Welcome to the AUA Leadership and Business Podcast Series, March 2022 episode entitled Primer on Private Healthcare Insurance in the United States. I'm going to be your host. My name is Dr. Micheal Darson. I'm a urologist with Arizona Urology Specialists in Scottsdale, Arizona, and I'm the current chair of the AUA's Practice Management Committee. We're here on the AUA Leadership and Business Podcast Series to discuss private insurance. Medical care in the United States can be expensive. Most people are covered by some sort of medical insurance, either private or government sponsored, but that has not always been the case. We are here today to talk about the current state of medical insurance in the U.S., focusing this podcast on private insurance. Our guest today we'll be talking with Dr. Jonathan Rubenstein. Dr. Rubenstein is a urologist with the Chesapeake Urology Associates in Baltimore, Maryland, and is both the compliance officer and medical director for coding and reimbursement for the United Urology Group, but also the chair of the coding and reimbursement committee for the American Urologic Association. Welcome, Dr. Rubenstein.
Thanks, Dr. Darson. It's an honor to be here. Nice seeing you today.
Let's get started. So why do we have private healthcare insurance in the U.S.?
Great. Well, private healthcare insurance, we could start by just saying that, as we all know, healthcare is expensive. That would be sort of the easy answer. But, this is really evolved, from 150 or 200 years ago when railroad and steamboat workers, had accidents. They're back in the 1850s and 1860s, a company in Massachusetts, the Massachusetts Franklin Health Insurance Company, helped cover some of the injuries and mostly of the lost wages that occurred. And what happened was that became a great idea, and companies figured out how they could make a couple bucks off it. Also, there was a need, and that idea sort of grew. Actually, it was in the 1910s, 1920s, the first employer-sponsored health plans, came into being, but it really wasn't to cover hospital costs or medical costs, but really was to help cover lost wages as a real insurance. 1920s, sort of the beginning of HMO started, where the nurse, in Dallas, Texas, a group of teachers, had a plan that was put together where they would get their health care all in one hospital setting. And over time, all these ideas evolved into a private health insurance so that people could actually get their health care coverage covered by, putting the money in. These were mostly employer-based plans. The whole thing really took off in World War II. There was a wage freeze, and there was also a worker shortage. So to get workers in, if they couldn't raise wages, they had to raise benefits. And that's why employers pretty much started covering health insurance for its employees. And ever since then, it's sort of taken off. And so therefore, health insurance in the United States, at least private health insurance, is mostly employer-based. You can also get some private-based plans, but it's majority employer-based. The reason Medicare really started was that because most healthcare in the United States was employer-based, elderly, especially those over the age of 65 who were not employed, they were having a more difficult time getting their healthcare covered. And that sort of led to the idea of having Medicare to cover those who were not covered by an employer-based healthcare policy, and also people with certain illnesses that couldn't also benefit from an employer-based healthcare policy. So over all the years, private health insurance has continued to evolve, and now we're here in the year 2022.
Okay. Can you explain the current types of private insurance?
Yeah. So private insurance, there's there's several major companies that also have national plans. A lot of these are state-based plans. There's also minor healthcare insurance companies, and for those who practice medicine, you may see wherever you're 10 to 20 to 30 typical plans. I think that our group has 17 major plans that we typically use for the majority of our patients. But so the individual gets to decide sort of where they get their healthcare from, especially those who are employed. So the majority of Americans get their healthcare through an employee-sponsored plan. The employer itself, puts together a plan as a benefit, with certain deductibles, copays, and amount that individuals pay into that plan. So also can get individual plans, either through major or minor healthcare companies. People can get their plans through a state or federal marketplace, especially ever since the Affordable Care Act. State and federal marketplaces have become much more common in a way that people get their health care. Some people, choose only to get, say, catastrophic coverage. And there's also short-term policies for people who are between plans. But again, the majority of private healthcare in the United States right now is employer-sponsored.
Okay. Can we go into a little bit more detail about each type of private insurance?
Yeah, sure. So, again, when you're talking about an employer plan, you're talking like a traditional plan, which is usually fee for service, which is a healthcare plan. They pay a certain amount for service that are provided. There's health maintenance organizations, which kind of help control costs by keeping a certain number of providers, and a certain amount that gets paid in every year covers all the healthcare costs. Those are there's a lot of different managed care techniques in trying to maintain costs. But that's kind of what you're looking at when we're talking about private healthcare.
So Dr. Rubenstein, you've done a really good job of telling us the types of insurance. What should physicians know about private insurance?
So, the thing about private insurance, remember, it's a good segue to the difference between like a Medicare or government-funded, government-sponsored plan, like Medicare, and private insurance. Medicare itself has, set guidelines, set standards that everyone is eligible for if they are a Medicare beneficiary. Private insurers, every plan really differs, and every plan can sort of make their own rules. Yes, there's a general set of health conditions and general set of procedures and services that healthcare plans must cover. But also there can be a wide variability in outside of that, what they cover. So, depending on the cost of the plan, depending on the type of plan, coverage can really differ. The co-pays can really differ. The percentage that patients have to pay themselves have to really differ. And what they cover differs quite a bit. The important part about understanding from a provider standpoint is that knowing what the plan that a patient has, what they cover and what they don't cover. On a day-to-day basis, as a urologist, I don't worry about our basic evaluation management of patients because we know that covers the basic procedures. The difficult part is when you get to more, I want to say, fringe benefits in a way, but I need to know if I'm going to do a certain prostate-related procedure, what each individual patient's private insurance covers or doesn't cover and what their rules are. And that is one of the challenges with private insurance. The thing about it is also sometimes patients don't know what their plan covers and doesn't cover. We've seen a lot of plans, especially a lot of employer-based plans, where the employer itself decided before the year what sort of services they would and would not cover for their beneficiaries in that plan. But a lot of times the patients don't even know. And that is one of the biggest challenges I find with private healthcare.
So let's talk about a little bit about the Affordable Care Act. You mentioned on a prior podcast that was the largest expansion of healthcare services since World War II. Can you give our listeners just a high-level view of what doctors should know about what the Affordable Care Act did for health insurance coverage?
So the Affordable Care Act, I would say the main thing was the expansion of the marketplace and the ability for citizens who would be otherwise unable to afford health care to be able to get into healthcare. Whether it was the fact that there was more money that went from the federal government to Medicaid, but also insurance marketplaces where people could get health care when they otherwise wouldn't. And the way that this occurred was that there was an individual mandate, and basically it was almost like like any insurance. When you talk auto insurance, the people who are paying in every year help pay for the people who don't need it every year. So that the reason that auto insurance works is that most people don't get into an accident every year, but then it helps cover the people that do. The way that this needs to work is that people who maybe are younger or healthier, who might not otherwise go ahead and put money into the marketplace by trying maybe not getting health insurance, would need to get a healthcare plan and help sort of pay in the goals that they would get it on the way out when they need it.
Okay, as the director of compliance and coding and medical director for coding and reimbursement, what type of challenges does your practice face with private insurance?
Yeah, well, so private insurance again. So not only do we have to have, again, somebody who actually helps create a contract every year, but one of the biggest challenges, again, we see is what an individual insurance covers or not, because every insurance company can create their own rules outside of their base benefits. So, for example, there's a certain surgery that a patient that as a practicing physician, I think is the best surgery for a patient. That surgery itself may not be covered by the individual plan. They may have certain rules. They may have a certain prior authorization rules, certain criteria that need to be met. And if they don't meet that criteria, the insurance company won't pay for it. And it's frustrating because sometimes if you don't do the due diligence beforehand, you end up doing the procedure and then not getting paid for it, which as a provider who's looking out for the best for my patients, I do things because I think what's right for the patient. It sometimes is difficult to know what an insurance company will cover or not, especially if there's an employer-based plan. An employer-based plan, even if sometimes we will look for a prior authorization or we'll look on the website for the company and what they cover or not. But the specific plan, the plan that's managed by the major insurance company, might not cover that service because the employer themselves for that specific plan chose not to cover it. But sometimes those are even difficult to find. Sometimes the main company itself doesn't even know whether they covered or not.
Well, that sounds pretty challenging. What are the pathways a physician has if like you said, they're trying to do what's best for the patient, and obviously they probably know the data better than the company. What is their pathway to try to get something covered?
Well, so listen, we all know we can do peer-to-peer, but we also all know that peer-to-peer, it's challenging. I think that Mike, you yourself are busy every day trying to take the best possible care of patients. Your days get busy, your days get long. Then to try and set up a time to actually then speak to another provider and the insurance company and tell them why you want to do something and why it's the best thing for the patient, that's just a lot of extra time out of your day. Certainly we all kind of feel frustrated. We feel like some insurance companies don't trust us, that we're trying to do the right thing for the patient. Peer-to-peers do exist, but that adds an extra layer of challenge in our days to try and get things done on behalf of our patients.
Okay. What other challenges? What about prior authorization?
So again, prior authorization, we have a prior authorization group that actually, will get prior authorizations. Always, obviously, you get frustrated when an insurance company has a rule in place that says, if you don't get prior authorization, we will not pay you for the procedure. Even if the procedure is the correct procedure, and they would have covered it if you had gotten prior authorization. If you didn't get prior authorization, that's an excuse not to pay you for the service that you performed. And that can certainly be really challenging. And because of contracts, you can't go back and say, but you would have covered if it got prior authorization. And they'll say, I'm sorry, you didn't get prior authorization though. Or sometimes you'll see denials because you got prior authorization, and when you got into the surgery, you end up having to do a slightly different surgery. Yeah, you can end up fighting it and usually winning those battles, but it's a lot of extra time and extra effort that I feel sort of unnecessary. A lot of us feel unnecessary when you're just doing the right thing on behalf of your patients. Tell me some of your frustrations, some things on your, whether a daily basis or weekly basis, some of the challenges that you see in your practice.
Absolutely. I think one of the biggest ones you've already mentioned is when you are working up a patient for a certain disease state and you know that there's a technology that's out there that works, that's got data behind it, that's FDA approved and all those things. And then you go to offer it to the patient and then they deny the service. And the denial of the service never really totally makes sense. It's just, it seems like a random choice that the company has made to not cover a certain treatment or procedure.
Yeah, I've run to the exact same thing. So I've had conversations with medical directors before, and the medical director says, sure, that sounds great. You should just call me when you want to get this done, and I'll probably approve it. But for me to try and do that every patient, every single time, again, the amount of effort that it takes, it would make practicing medicine very difficult if we had to do that on every procedure every time. Especially right with new technologies that come out that that would benefit a patient better than a current technology. But if it hasn't been reviewed and put into policy by a private insurer, it wouldn't even matter whether you knew that it was better for the patient, that it had better outcomes, fewer risk complications, or was specific for your patient, why it was better based upon published literature, good literature. If it's not in their policies, that patient would not be able to get that or at least get it paid for.
So if there's an emerging technology, we'll just say some futuristic prostate cancer, focal therapy, how does a private insurance company be forced to look at the technology and the data to offer coverage? And maybe forced isn't the right word, but how can they be educated that there's something out there that works better than some of the things that they already cover?
It really has to be a personal phone call. It has to be they have to reach out to medical directors. I know people who will have decent relationships with the medical directors, some of the private insurance companies in different regions, and they'll pick up the phone and call and say, hey, we think that you should offer this to the patient. Then it goes through whatever process they need to go through. They look at the literature, they look at the cost, they look at the inclusion-exclusion criteria. Then they might come up with a policy. But typically that would take, even if it went through quickly, it would still take time to get through. And so new technologies can be challenging. I guess that the best thing to do is, if something really benefits the patient, it takes the effort, it takes the time. Sometimes there are certain private, the companies who may run the technology will reach out. I actually find that physicians themselves get through a little bit better than sometimes the companies do. But it is challenging. There's new urology technology that come out every year. And if we want them for the patients, we need to pick up the phone and call our insurance companies. A lot of times they're not either going to take the time or the effort to try and look through different technologies unless there's a reason for them to look through it.
Okay, we talked a lot about the challenges. What are some of the things that you like about private insurance?
What I like about private insurance, listen, healthcare is expensive, and people who need healthcare who have private insurance, aren't going to be overly burdened by, huge medical bills if it's within reason. I do like that health insurance does pay for screening, preventive care. I would actually encourage, private health insurers to continue to make, especially screening, as affordable as possible. Minimize deductibles, minimize copays, to get people in to see their doctors. I think there's nothing better than when people do show up with their doctors. And I tell patients all the time, I think that doctors are best when they tell you what you don't know that you don't know. And that's the reason to go to doctors. Even young, healthy people who don't show up to the doctor, don't get their yearly screenings and yearly check-ins. I think that can be really problematic by missing an opportunity to catch something before you realize it can be a problem. And our screening guidelines change every year. The colonoscopy guidelines change. And if we don't get patients encouraged to go see their doctor, we might not know the newest guidelines, which might end up, helping save a life. So I do like that about private insurance companies, that they do cover a lot of the screening visits. I would, if somebody's listening out there, I would encourage them to try and make that as affordable as possible.
Yeah, I would agree that I think that it almost allows easier access for the people that have private insurance to get in to see doctors for exactly those reasons. And we all know that screening saves lives. So
yeah, it does save lives. One thing I would change. I would love if when patients get EOBs, explanation of benefits, they get their kind of the bills in the mail, and it shows what a doctor charges and what they got paid. I almost want them to leave the doctor's charges off it. I don't know how many times you've gotten a phone call, an angry phone call about some huge charge that one of our doctors has charged, but by contract that doctors don't actually get paid that. I've had too many people who've looked in the first thing you look at, here's the charges, and then it actually says, here's what we actually paid the doctor, and they say, I can't believe the doctor charged that. I can charge whatever, I can charge whatever I want. I could charge $1 billion for I'm not getting paid for it.
Right. Yeah, no, I've had a few of those calls.
we all get those calls, but when you get the angry calls, then I tell them to look at the next line, and they say, "Oh, thanks. That makes a lot more sense."
Right. So that's an interesting segue into a potential discussion about surprise billing.
Yeah. So listen, this year, starting in January of 2022, the No Surprises Act came out, which I think most providers would agree is a great idea. What you don't need to do is be traveling through a different state and have an emergency medical situation and then suddenly be burdened down by bills that would financially ruin people. So the idea and the architects of the No Surprises Act, I think, did a nice job, and I think most providers can agree that it was a really good idea. But of course, the devil's in the details. Obviously, there's a lot of controversy with the No Surprises Act, especially how if there was some sort of controversy between provider and the patient's insurance company, how that gets settled out. So hopefully, over time, the No Surprises Act can be worked out in a way that is beneficial both to providers, insurance companies, and patients in a way that everyone can agree is a good system.
This brings us to the last topic that we have. Can you tell us about telemedicine, telehealth, and its future with private insurance?
Right. So, again, just like it did with Medicare, telehealth really exploded when COVID exploded, March 2020. Really, it became really quite commonplace that telemedicine became just a natural part of practicing medicine. We did realize a couple things through this telehealth expansion was that there are a lot of patients who need to be seen in person, And there's a lot of patients that can have just as good a healthcare through telemedicine, which can save time, which can save travel, which can save money, which can just reduce the hassle. I mean, yeah, as from personal experience of being a patient, sometimes taking a visit when I don't need a physical examination from my place of work or my home will save hours upon hours on a day traveling and all that stuff. It was disheartening to hear that, as at least the first wave of COVID was going down, that a lot of insurers were thinking about rolling back their telemedicine visits and telemedicine benefits. COVID then had another wave, and so far it's pretty much stuck. My hope, and I think most providers around the country would continue to hope, that private insurers not only would continue to cover telehealth and telemedicine visits, but would actually encourage telehealth and telemedicine visits for the appropriate patients. Some patients really need to be seen in person. Some patients really need a physical examination, but those who don't, especially those who are still employed, working in school, telehealth benefits are so important that I would personally stick with a plan, only one that had telemedicine visits.
Yeah, I know that here in Arizona, we draw from a large geographic area north of Phoenix and west of Phoenix. And there are people that drive 2 and 3 hours one way to see us, and for, a review of a KUB, Yeah. So it's, I hope that our legislators help us with this after the public health emergency is declared over.
Yeah.
So.
Well, and some of that's obviously state by state. Also, some will demand that if you're a state-based insurance, to cover telehealth and telemedicine visits. But I think that all of us as practitioners all can understand the potential benefits. Obviously, there's always a few potential concerns here or there, but I think that we can all agree the benefits are outweighing the risks on telehealth.
Well, do you have any other closing remarks?
No, I just encourage people to understand what their private insurers cover, what they don't cover, what their rules and regulations are, because at least the physicians who I work with, they're good doctors. They want to take good care of patients. They want to take the best care of patients. And sometimes it's important that they understand that taking the best care of patients also means that making sure that you follow insurance rules so you can get paid for the work that you do. Physicians won't be able to continue to practice medicine if they're not getting paid for the effort that they do. So they do need to understand the rules. They do need to understand what a private insurance, covers, what they don't cover, and make sure that we mutually take the best care of patients. And there are going to be patients every now and then where we just have to pick up the phone and call a medical director to try and explain why we need a certain service done on a certain patient.
Well, Dr. Rubenstein, that was an excellent summary of private insurance. We would both like to thank the audience for taking the time to listen to us today. And the AUA and I would like to specifically thank Dr. Rubenstein for taking the time to educate us all.
Thanks, Mike.
Yeah, you bet. To listen to additional podcast episodes in this series on leadership and business, please visit the AUA Inside Tract Podcast at auanet.org/podcast.
Thank you for listening. For additional episodes in this podcast series, please visit the AUA Inside Tract Podcast at auanet.org/podcast. If you have any research focused on leadership, business, or practice management, please consider submitting your article to AUA's peer-reviewed journal, Urology Practice. For instructions for submission, please see auajournals.org and click on Urology Practice. This journal publishes cutting-edge articles on clinical trends, challenges, and practice applications in the 4 areas of business, health policy, the specialty, and patient care.